This is my student ID card. Today I'm going to be talking about the case study Amira. Uh, um, Amira has stage 3C invasive duct carcinoma. Hello everyone. Today we are going to analyze the clinical journey of Amira, a 44-year-old woman facing a diagnosis of stage 3C invasive duct carcinoma. Our focus today isn't just on the pathological, but on the integrated approach to her surgical recovery, pain management, and multidisciplinary support required to return her to her life and her 4 children. We will move through her diagnosis, the physiological drivers of her disease, and the acute and long-term care plan necessary for her recovery. There is a cross-section diagram of breasts showing the mammary glands and the lactoferrin duct. Amira's diagnosis is invasive duct carcinoma, or IDC. This is the most common form of breast cancer. Pathologically, IDC begins in the epithelium of the lactiferous ducts. It becomes invasive when it penetrates the basement membranes to invade the adjacent stroma. In Amira's case, the disease is classified as stage 3C, which means it is locally extensive, having spread to the pectoris major and serratus anterior muscles of the chest wall and metastasized to the axillary lymph nodes on the same side. Why did this happen to a healthy 44-year-old? The answer lies in her genetics. Amira carries a BRCA1 mutagen, or inherited autosomal dominant trait. Normally, BRCA1 is a tumor suppressor that repairs double-strand DNA breakages. Without it, the probability of invasive carcinoma skyrockets. At the cellular level, this leads to uncontrolled growth, neovascularization, and resistance to apoptosis, which is cell death. These tumor cells damage her local lymphatic structure, allowing cancer cells to break away and seed in the regional lymph nodes, which specifically increases the risk of distant metastasis, which is like where the cancer moves from one place to another. Following her modified radial mastectomy, it's when they cut the cancer, Amira's immediate need is a multimodal pharmacological plan. We cannot rely on one type of medication because her experience is with 3 distinct types of pain: acute inflammatory, chronic inflammatory, and neuropathic. While NSAIDs handles inflammation, they do nothing for nerve pain. We must use scheduled medication to maintain consistent plasma levels, rather than wait for Amira to be in agony before providing rescue doses. Targeting neuropathic trauma. Amira specifically reported pins and needles in her right axillary. This is a classic indication of neuropathic trauma to the intercrossbrachial nerve, often disrupted during an axillary dissection. Standard opioids are notoriously ineffective for this specific sensation. Instead, we utilize gabapentinoids. Gabapentinoids modulates calcium channels to block abnormal neural firing, providing relief while actually allowing us to reduce the overall opioid intake, thereby avoiding side effects like respiratory depression or bowel issues. Beyond medication, we use physics by placing a pillow under Amira's arm so her hand is higher than her elbow and her limb is above her heart, which utilizes gravity. Removing lymph nodes disturbs natural drainage. Elevation facilitates venous and lymphatic return, reducing localized edema and the painful stretching of her structures. These simple acts can decrease her anxiety and help her focus on essential deep breathing exercises. Discharge education, drain management. Amira is going home with two closed suction drains. To empower her, we must teach her to aseptically empty the reservoirs and record daily totals. So she needs to know exactly when to call us. If drainage stops suddenly, if there is foul odor, or if her temperature exceeds 38 degrees. These are clinical markers of identification infection before it becomes a crisis. Limb preservation strategies. A vital part of Amira's new normal is limb preservation. Because her lymphatic system is compromised, she must strictly avoid blood pressure monitoring, venipunctures, or vaccinations on her right arm. Furthermore, she must not lift anything heavier than 2 to 3 kilograms. This is significantly challenging for a mother with a 2-year-old, which brings us to the necessary of her support team. Multidisciplinary integration. A group of doctors, nurses, social workers are needed. Amira cannot do this alone. Her care team includes the breast care nurse to coordinate clinical care and support her children, lymphatic therapist to restore her range of motion, a genetic counselor to discuss the implications of her BRCA1 mutagen for her children, a social worker. Crucially, the social worker evaluates home safety and coordinates domestic assistance so Amira can rest without the physical strain of her maternal duties. In conclusion, Amira's case highlights the treatment stage of 3C cancer requires more than just surgery. It requires an understanding of genetics, predisposition, sophisticated multimodal pain management, and a dedicated team to support the patient's transition from hospital back to her family. Thank you for listening and thank you for your time. These are my references.